All right, we're going to go ahead and press the record button so we can share this later, but we'll go ahead and get this presentation started. All right, I really want to welcome everybody who's joined us today for our very first webinar of 2021. We appreciate the time that you've taken away from your busy schedule to learn more about PBA and our offering, and in particular, the offering with the Mayo Clinic and their programs. Before we meet the Mayo team and dig into the complex care product, I'd like to give you a little background about why PBA believes in this solution and why we're presenting it to you today. 4 years ago, we started a program that we call PBA's FOCUS Care. The intent of the FOCUS Care program is to bring our clients and brokers the best-in-class solutions to help control the cost of your health plan. Most of you understand that 80% of health plan costs are generated by about 5% of the covered participants. Our FOCUS Care programs address the conditions that contribute heavily towards these expenses. Our 5 partners in FOCUS Care address, of course, the diagnosing multiple conditions through Mayo Care's Complex Care program. We also address musculoskeletal conditions, specialty drug, infusion management, patient advocacy and coaching, as well as diabetic health coaching. In order to participate in PBA's FOCUS Care, not only do our partners have to prove their value, they cannot add to the administrative cost of the plan through the per employee per month fees. So it's really important. All products are available to all plans, and the providers get paid when they actually do the work, adding value to the member and to the plan. So in addition, PBA is not just a TPA, we're also an employer. And when we have a self-funded health plan, so we bring all of these programs to our own health plan and our own staff to make sure that they add value and meet our service standards. If a service provider can't take care of PBA's family, we can't trust them to take care of yours. So as you'll learn shortly, the Mayo Clinic has much more to offer than just complex care, but that's where our collaboration with them begins. We're proud to say that PBA is the only TPA offering this benefit to all of our clients. And this is a great advantage to you because Mayo typically doesn't work directly with employers who have less than 20,000 covered lives. So one of the things that really stood out to us about the Mayo program is the team approach to finding and qualifying patients to get them into the system. I know you're all familiar with patients that you've worked with who suffer with multiple conditions and what the end results of that are. So many of the treatment decisions are decentralized and the patient is left to decide on their own what the next move is. So at the same time, they're incurring expenses and receiving treatment that may or may not be in their best interest. The Mayo program gives the patient and the plan the ability to reset, remove barriers, and look at the patient as a whole person and not just a bunch of diagnoses. And again, there are no PEPM access fees. So as we get started, please note that you're currently muted. If you have any questions that come up throughout the presentation, please feel free to type them into the Zoom chat box at any time. We have left time at the end of this presentation to answer your questions, and based on who's joined us today, we know we're going to have them. I'm very excited to introduce our team from Mayo today, and these guys are responsible not only for pulling this program together, but making sure it works on an ongoing basis. First, we have Elizabeth Rice. She's the program administrator who oversees the program that we're presenting today. Cheryl Nienhuis is the director of the Mayo Clinic Complex Care program. She works with employers, brokers, and with TPAs to make this all happen. And then Molly Sweeney is our senior account manager who works directly with PBA for the implementation and day-to-day navigation of this program. So whenever we have a candidate, we're talking to Molly. So without further delay, let me hand over the presentation to Elizabeth. Take it away, Elizabeth.
Thank you, Jeff, and thank you everyone for being with us today. We appreciate this opportunity to be able to share our collaboration with PBA and our program with each of you. So by way of getting started, just a little background on Mayo Clinic. So hopefully most of you are well aware of Mayo Clinic and have some experience with our brand. Our mission is truly to inspire hope in our patients and in our communities. And the way that we do that happens by providing care to patients who need Mayo Clinic level care. And so we have a program that we're going to share with you today that really helps to figure out how we can identify and inspire hope for the employees and members that you all are serving. Mayo Clinic is ranked as the #1 hospital in the world by US News and World Report. We've also been ranked the #1 hospital in the world by Newsweek recently. So clearly a leader in quality, and we see more than 1 million patients a year at our 3 campuses, which are in Minnesota, Arizona, and Florida. One thing that is unique about Mayo Clinic and that we like to ensure that people are aware of is that our physician staff are all salaried W-2 employees. And so they have no incentives to order more tests or do more procedures than is really what's in the best interest of the patient. So our physicians, if it's a surgeon, they're getting paid the same amount, whether they're spending 2 hours with a patient explaining why they don't need surgery or whether they're in the OR for those 2 hours. And that is something that really helps keep that focus on inspiring hope and the best needs of that patient top of mind. We also have a spirit of collaboration that really permeates across the organization. And some of our medical directors will tell you, when you're working with the world's best experts, there's some peer pressure to make sure you're consulting with those friends down the hall and getting the diagnosis right and getting the treatment plan right for each patient that you're seeing. And so that is second nature to all of our providers, and just working with kind of the basis of more minds are better than one, and let's figure out how to best treat these patients. And so just wanted to provide that kind of background on culture and mission for Mayo Clinic. Now, what we want to talk more about today is really complex care and why we want to focus on that, and why you all should have this as kind of a strategic priority in your minds. And probably none of this is news to you, but clearly patients who have complex or serious issues, the costs are very high. The quality is variable based on the market that they're in and the type of healthcare that they have access to. In many markets, the patient experience is poor because they may be needing to see multiple different specialists who are not communicating with each other or work for different practices or different hospitals. And so the patient is responsible for trying to connect the dots and share clinical notes and share records and schedule the appointments and tests that they need. It can take months to even coordinate multiple specialty visits and tests. And so the patient experience is often not ideal. And they may not also have access to the latest and greatest in scientific advances, depending upon their location and the centers that are kind of within reach. So that's really why, and you heard Jeff mention at the beginning too, that small percentage of a population that is driving a significant portion of the plan costs. And those are typically the complex patients. So that's why we have developed what we call our Mayo Clinic Complex Care program. And it's really a customizable offering that is focused on just that small percent of a population and ensuring that they have the right diagnosis and the right treatment plan for their complex condition. So we're not looking to have a large portion of any population traveling to one of our campuses for care, but we do want to break down barriers for the individuals who need care at the Mayo Clinic level to be able to access that care and ensure that they are on the right diagnosis and the right treatment plan. Our program, because Mayo Clinic has virtually every subspecialty of medicine represented, our program can be as broad or as narrow as needed for an employer. So we have some groups that are really looking at specific programs for cancer or for spine, but many who leave the program very broad for whatever needs may come up for their population, and leveraging Mayo Clinic for those individuals as necessary. So the way that we're breaking down barriers for your populations with PBA is kind of threefold. So the first is a product that we call an e-review. And that's really an electronic medical record review where we work with PBA, who gathers, and a case management team who would gather the medical records. And we would ensure that those records get to a Mayo Clinic subspecialist in that particular diagnosis for them to review and make a travel recommendation. So the Mayo expert will say, yes, this patient should travel to one of our campuses for further evaluation or diagnosis. And that would mean that we think we have something new or different to offer to that patient. Or they may say, no, this patient doesn't need to travel. And really that means that the patient is on the right treatment path at home, and it doesn't make sense for them to spend additional time or money seeking further care at Mayo Clinic. And the way that the e-review is intended to work is to really limit utilization to those individuals who will most benefit from care at Mayo Clinic. And so that, I think, is a valuable product that we can offer to help really funnel the right patients into the program. Once a patient is referred into our program, we have what we call managed access. So that means expedited scheduling. We're going to get that patient in as quickly as possible and condense their appointment itinerary to be ideally 3 to 5 days. In those 3 to 5 days, there's going to be potentially multiple specialty consultations and treatments if necessary, testing. We'll try to get it all done in a short amount of time to get that individual back home, back to work as quickly as possible. And then we work with employers to adjust benefit design and ensure that we're breaking down any financial barriers that patients may have to accessing the care that they need. So that would include the employer providing a travel and lodging benefit, so paying for airfare, mileage, or hotels, and waiving prior auth so that they're not sitting around our campus waiting for prior authorization to move forward with a test or a procedure. And then when possible, we ask the employer to waive any co-pays, deductibles, co-insurance, out-of-pocket costs for that patient that might prevent them from seeking that care. So really in the big scheme of things, most of those deductibles probably have been met often for a lot of complex patients, and the travel costs are pretty minimal. So the employer breaking down those barriers is generally a pretty reasonable from a cost perspective.
And Elizabeth, I can't agree with you more based on the experience that we've had personally within our own population, as well as within our plans that we administer. Just a footnote, we try to make sure that all of our plan language is updated to accommodate the ease of using this system, because we know that when a patient is already going down a road with a diagnosis and with a doctor or with multiple doctors, getting them steered over here doesn't need another barrier. So I think that's why it's really important that you point out that we're breaking down barriers as much as possible by taking that cost away from the patient and really looking at the overall cost of this person, this episode, this condition, and really helping them along.
Yeah, perfect. Thanks, Jeff. And I think, what we often talk about is the costs associated with a misdiagnosis are significant. So any treatment that is following something where the diagnosis isn't right, or diagnosis needs to be clarified, or maybe there's a different or better treatment option for that patient, that's really where the long-term cost savings and improved outcomes come for patients. So on the screen now is just really kind of a summary of what we see as the value of the high quality care that we can provide through our program. So it starts with getting that right diagnosis, having access to the kind of latest and greatest in medical advances, our ability to provide a seamless experience for the patient. We're coordinating all of those appointments across specialties, across testing or labs that need to happen, so that we're taking that burden away from the patient and making it easier for them to both access that care, but also for the providers involved in their care to share and communicate and collaborate on that right diagnosis. I mentioned earlier our salaried physicians, so that often results in significant cost avoidance, especially when it comes to things like unnecessary tests or procedures. And we are a leader in patient experience, and we'll talk a little bit more about some of those metrics in a bit.
So for anyone who's wondering, because I know who's in the audience today, for anyone who's wondering, yes, we have done the evaluation, and yes, they are not charging per the, trying to incur that extra fee for those services. They have turned plenty of people away.
Thank you, Jeff. Yeah, our goal is really to get the right people the care that they need. So thank you for that. And then, as Jeff mentioned in the beginning, we don't charge any kind of administrative fee. Our goal is the same as that of PBA, in that we only want employers to be paying for services that are provided. So there is no PMPM or PEPM for the program. The only fees would be for that e-review, where we're taking subspecialist physician time to review medical records and make a recommendation. There's a small fee for that. And then if our travel team is booking travel, there's a small fee to cover those travel agents. But our goal, again, is just to get the right people in the door and break down the barriers in their ability to do so.
That small fee is small. It's less than $100. So we're not talking about big travel expenses there for the booking.
Yeah. So next, we'll dive in a little deeper to some of the specific care models and provide some case study examples of our current clients. And so first, we wanted to talk about cancer because I would say that probably 99 out of 100 times, this is what comes up first for any employer that we're talking about as the largest contributor to their claims and kind of their biggest area of concern. And we are a well-known and well-respected cancer center across all three of our campuses. We believe that the cancer care model especially is where that e-review comes in and is very valuable, because we aren't suggesting that every single cancer diagnosis that patient should travel to one of our campuses, but having the ability to triage individuals with an e-review really can drive the right patients that have more rare and unique cancers or may have different treatment options into the program. We have all of the kind of latest and greatest advances in cancer therapies, including CAR T-cell therapy. We'll talk a little bit about hypofractionated proton beam therapy, which really allows us to reduce the number of treatments that patients get, have better outcomes and lower costs. And a lot of other, the newest things are often available first at Mayo Clinic, because we have the researchers that are working on that and have the opportunity to enroll patients in clinical trials as well. So I wanted to share one case study with you. This is from a very large employer who we've had a long standing relationship with, and they are offering a voluntary cancer benefit that includes that e-review product that we've been talking about. So as patients are identified and submitted for e-review, about 45% of those individuals that we review records on are recommended to travel to one of our campuses. Now, this program is primarily for the most common cancer types, so breast, prostate, lung, colorectal, and blood cancers. If the program was more broad and included more rare and unique cancers, that percentage would probably be a little higher. But for those most common cancer types, less than half are recommended to have further evaluation or treatment at one of our campuses. When we did a record review of 364 patients who have come to Mayo Clinic to one of our campuses based on that e-review recommendation over the past 5 years, 32% of those individuals had a change made to their diagnosis. So that could be a complete change in diagnosis. It could be a clarification or an additional diagnosis that was added. Some of the patients did not even have cancer. And so that is one of the benefits of our program, that we have the other expertise that if it turns out it's not a cancer diagnosis, we're able to manage that patient as well. 77% of those individuals had a significant change made to their treatment plan. And so this is really, I think, telling as far as the value of the program and ensuring that those patients are getting on the right path for treatment and starting with that right diagnosis. So next, we'll talk a little bit about transplant. Transplant's one that, depending upon the size of your population, it may not come up as frequently because it is a smaller percentage of the population, but very high spend for those and very complex. So as Mayo Clinic, we are the largest transplant center in the US, and we offer all of the solid organ and blood and bone marrow transplants. We do more than 2,000 per year. And it's really a unique program because it's coordinated from pre-transplant all the way through long-term follow-up with nurse coordinators. When you come to one of our campuses, there's a transplant center, and all the specialists come to you, and they're transplant-specific specialists who know how to manage patients who are either pre or post-transplant. So it's a very unique and coordinated experience for those individuals. So one example of where a transplant program can really benefit both the patient and also the plan from a cost perspective is our living donor kidney transplant program. As many of you know, when patients are in end-stage renal disease, generally a local nephrologist will refer them to a local dialysis center, and they will begin down the path of dialysis before they're listed for a deceased donor transplant sometime in the future. Our researchers and physicians have done a lot of study in this area and really recommend a living donor kidney transplant prior to a patient going on dialysis. The outcomes are better for that patient. Quality of life is improved because they're not having to spend years on dialysis. And significant cost savings can be achieved by avoiding dialysis. So we have some really specific criteria that we can share and that PBA is aware of. So when there is a patient that has end-stage renal disease and meets some of the qualifying criteria, they can be referred to Mayo Clinic, and our nurse coordinators will begin working with them, helping them to consider identifying a living donor. We have what we call a paired exchange program. So if you have a donor who is not a match for you, but is willing to donate, we can pair different donor and recipient combinations to ensure that the right kidney is getting to the right patient and enable additional living donor transplants. I think our longest string is about 18 transplants that were able to happen because of paired donation. So a fantastic program, the right thing to do for the patient, and significant cost savings as well.
You know, Elizabeth, I really was impressed when you guys shared all the information with us on that living donor transplant. And honestly, I think someone from your staff was actually a participant in that and had donated one of his kidneys when we first met you. And just sharing that personal story is very moving, that difference you can make. You know, in just talking to who we have on this call, just a couple of points that I'd like to make here. Mayo Clinic is very active in most transplant networks. So if any of you have programs where you've integrated the transplant network and carved that out from your reinsurance, they are typically going to be part of that network. And so that these will be covered expenses under your stop loss plan as well. So.
Yes. Thank you, Jeff. And then lastly, we wanted to talk a little bit about what we call Diagnostic Odyssey. So Diagnostic Odyssey patients are really those individuals who are potentially undiagnosed, searching for answers, generally wandering kind of throughout the healthcare system, seeking answers. They often have multiple specialty visits throughout the course of a year, possibly multiple emergency room visits. Their utilization is very high because they're having some sort of symptoms that really have not been managed via their current treatment plan or have not been diagnosed. This is where I think the magic of Mayo Clinic really kind of shines through. So because of our collaborative practice and model of care, and because of our broad expertise and willingness to work together to kind of solve these medical mysteries, this is something that we have significant expertise in. We have a process for having sort of a quarterback physician who is the one that is coordinating all of the different specialty visits, potentially translating things across those providers into the patient to ensure that the patient is informed and listening to the patient to really get to answers and right diagnosis and a treatment plan that will work for that patient. What we've heard from some of our current clients is that when a patient comes to Mayo Clinic for a Diagnostic Odyssey visit, sometimes these can take a little longer than 3 to 5 days, depending upon the number of specialties that are involved. But we have heard that potentially the utilization for that individual drops by as much as 60% after they have come to Mayo Clinic and get the answers that they've been seeking. So again, a significant opportunity for cost savings and for getting the patient kind of back their life and hopefully answers and a treatment plan moving forward.
It's such a complex system. It's great that you can do that.
So the last thing we wanted to share kind of on the case studies and care models is really just an overarching slide here that shows our results. So we recently went back and reviewed over 1,000 patient records of individuals who have come through our program from 2015 through 2020. This includes patients with cancer, Diagnostic Odyssey, spine, or other conditions. And as an overall program, we're making some sort of change to a diagnosis almost half the time, and we're changing a treatment plan about 80% of the time. So I think this just really speaks to our ability to identify the right patients that need Mayo Clinic level of care and get that patient on the right plan and really back to living their lives. So next, I just want to turn it back to Jeff, who is going to share a couple really specific examples of PBA patients who came through our program and had some pretty impressive outcomes. So
thanks, Elizabeth. And I think to your last slide too, the fact that you're at that 49% just doesn't mean that you've got that many people that are coming in and then changing the diagnosis. I want to re-emphasize that you're screening out people that shouldn't be coming to you in the first place. So at the point that we make that decision, we're steering that patient into your evaluation, that it's really making that happen. And I think that's right where my slide picks up, because here we have this first example, and now PBA's got a number of examples over the last several years, and that we've been working with Mayo. And the first one that we wanted to point out here today is exactly what we just pointed out. This person was originally diagnosed with stiff person syndrome, which is a very rare combination of an autoimmune disease along with a nerve basic disorder. So because it's very rare, I think the red flags went up. How can this be happening? Anyway, the treatment that they were going down the road with the different therapies and the Rituximab, it was a very expensive plan that they had this person on, and they weren't receiving the benefits. They weren't receiving the relief from the pain that they were in. So by bringing them through this program, we're able to rule out that this was not a stiff person syndrome, but it really was chronic pain that they were suffering from. But by getting them onto a new pain management treatment and getting them into rehab and actually taking them off the medications they didn't need, number one, I know we always jump to the numbers, but number one, we made someone's life much better. Okay. If you just think about the pain that people are in and the indecision and the not knowing what's going on, that's the first thing that we really took out of here. But then back to, what you guys are doing with the plans that you're working on, we were able to make an annual plan savings, annual, just on the drugs alone, not on the future care that would have been misappropriated, of $171,000. So think about stop loss renewals, think about what that actually means to the health plan. All right, and then the next one, this one is a little more complex and a little more finite. And this is basically, it's a rare form of a kidney cancer that this person was suffering from. And so originally they were going to go down a number of different surgery paths that they were going to approach this level of care with, including some pretty aggressive drug treatments every 28 days, which were going to be very expensive. So again, and I'm not going to put any words out there that I can't stand behind. The Mayo Clinic team comes to the table, reevaluates exactly where this person should be going. And by changing to a palliative care process, they were able to get this person on the right path again, improving their lives, avoiding a number of unnecessary surgeries, creating an annual cost savings of between $450,000 to $500,000. So again, these are just two cases. We've got a number of them. Honestly, we want to get more. And one of the things that we do struggle with is how to get patients at that earlier stage in the game. And one of the things that we really believe in, and Cheryl will talk about it in a minute here, is how can we get the patient on that journey to take that left turn, take that right turn, to get them down this other path, to at least evaluate what they should and could be going down next. So with that, I'll turn it back over to Cheryl.
Okay. Thank you, Jeff. So yes, a lot of you are wondering probably, how does this work, right? How do we make this happen for the populations that we serve? And so we really work with you all to go through that identification and referral process. And we'll get to that in a bit too. But Here are some of the areas that have proven to be very successful in getting individuals into that identification and referral process. So really looking at the claims data has been extremely beneficial, looking at the areas of spend, CPT, DRG codes. There are people that use the pre-cert prior auth flag as an opportunity to kind of take them off of that main path and transition them over to a triage or go through a review based on the type of pre-cert or prior auth is needed. So PBA is key in this identification and referral process, and we'll really work with you all and clients to identify what the best needs are for that population and what we want to do from a patient identification standpoint. We know that HR gets hit a lot with some of these employees coming to them or supervisors that are coming to them because they have employees that are battling and struggling with a condition. So we want to make sure that they have the referral stream identified too, and where to send people. Also, we have patient self-referral here. And again, this goes back to what Jeff was saying earlier. It's, we want to make sure it's the right people that are coming to Mayo Clinic and getting that right care. And so really that patient referral is not straight into Mayo Clinic. It's actually into that case management or that navigator or that concierge service, that TPA service, whomever is that group that is really helping take care of that individual or individuals who may be dealing with complex conditions. They will go through, we work with them and train them through the program and what to look for and work with them. They go ahead and actually do triage for that individual if they are interested in self-referral. And what's really beneficial about that is we're not waiting, while it's great information, we're not waiting for the claims data and the scrubbing of that data to identify the individual. So this person can literally come out of a doctor's office with a stage 4 cancer diagnosis, and they can make a self-referral into the program to talk to the right people from a case manager standpoint. Once that referral is made into Mayo Clinic, there's additional steps that we take, again, as Elizabeth had mentioned earlier, to identify if the patient would benefit from care at Mayo Clinic. So here is just a brief example of that patient journey, but it's really collaborating with PBA to work with you all and identify what areas of interest would benefit an employer group or a group. So work through that. We also work with the service partner who's answering the phones, who's taking those triage questions, who's looking at the data to really we work with them from scripting to identification to following your gut, so we work with them on what those criteria are. Once that patient calls in to that service partner has the opportunity to discuss the program and bring it up if they feel that this individual would benefit from care at Mayo Clinic. So they talk through the program with the patient. If the patient agrees to getting a review or being sent in as a referral to Mayo Clinic, that service partner will go ahead and submit that referral into Mayo Clinic. Mayo Clinic will then reach out to that individual within 2 business days or so, work with that individual on medical record review and gathering those medical records if necessary, or if that service partner has them, we work through that in the implementation process on how to get those medical records to us. Once we gather those medical records, Mayo Clinic, like Elizabeth said earlier, will actually have that subspecialist review those records to see if that person would benefit from care at Mayo Clinic. If that person does benefit from care at Mayo Clinic, we will work with that patient to coordinate appointments and book travel and lodging as needed. And I would say, we can reach out and schedule appointments a lot of times within 7 to 13 days. But again, it's really taking a step back and listening to the needs of that individual as that patient, as that employee, as that mother, that caregiver, that provider, to make sure that when we're providing them appointments, it's working with their schedule, because we understand that it's taking them out of their community for several days. And we want to make sure that they have the time to actually get their ducks in a row so they can have a successful appointment at Mayo Clinic. So as Elizabeth also shared earlier, that appointment schedule is condensed, and we work with that individual to get them into the right appointment and create that itinerary even before they come. So once they come, they meet with the physicians, they get testing done, and they're hitting the ground running to make sure that we can get that diagnosis right and that treatment plan right, and they get that evaluation for care, and then they can transition back to their local community for that ongoing treatment plan and that ongoing care. What's great about this part of the program too is that service partner that did that initial referral into the program, they actually have access to CareLink, which is an Epic platform that will show that service partner where they are within their journey, even at Mayo Clinic. So as appointments take place, as notes get put into the system, they are able to see all of that. And what's really beneficial is when they get back to their local community for care, that service partner will also have that care plan, right? So not only will that local provider get it, that service partner will get it, and the patient will get it on their own patient portal, which we walk them through setting up so they have access as a patient to their appointment schedule and the notes and the next steps as well. So really, that service partner can meet that person right back into the community where they're at and provide, again, that seamless opportunity for care.
So if I could just highlight there, you talk about that service partner a couple of times. So that service partner could be the case manager, the PBA is engaged, that's talking to the patient, that's talking to the local doctors. They can see this, they can see all this information. And so we're not disjoined anymore. We're not sitting here in all these separate silos. And now at the point that we've got this patient back home, we have access to all this information and are able to continue to update it as well. Then one other thing I wanted to highlight before you got too far from it, Cheryl, was you had mentioned, and I'm really glad you had that on there, the HR office, because there's some stuff that's really there. Because one of our biggest struggles is getting people engaged, getting them over this hump and turning away from that provider that they're currently working with. The HR can see things long before they're actually receiving treatment, just in the case that people are taking time off for medical conditions. And I know there's concern about HIPAA, but there's a lot of times, I would say a majority of the time, especially at PBA, where the HR always knows exactly what's going on with that patient and can help steer that patient as well, because they've got a whole different perspective. So I'm glad that you're able to include that in your presentation.
Yes, you bet, Jeff. And just to kind of add to that too, if there's any questions once that patient goes back into their local community, that patient portal provides them access to connect with their provider by sending just a simple, quick message. It's an easy to use tool where they can actually send a message straight to that physician and that physician's care team. PBA also, as case managers, if they have questions or concerns, that's why we have Molly here. She is really involved in the day-to-day connection points. And so on both sides, the patient as well as that case management team, PBA has access to Molly, and Molly can triage whatever is needed for the practice on behalf of that patient or what that patient may be sharing with that case manager. So it's really a seamless process, even behind the scenes from an operational standpoint. So what that does in that relationship is really provide a positive patient experience and patient outcomes. And so we have done 184 patient reviews, that are people that have answered the survey that we have done, and that's administered by Press-Ganey. And out of the individuals that have come in 2020, 184 of them, 98.9% rated Mayo Clinic as good or very good. And that's the top two on the scale of likelihood of recommending this program and this practice to others, because they've had a positive experience, because they've seen that fragmented care disappear by working with PBA and Mayo Clinic and you all to make sure that they have the right access to the right care. So with that, how does this happen? How do you build this program? Really, it's collaborating and working together to customize an offering. Elizabeth had shared some of the top areas of our care models. However, if there's areas that you're all working with the client or an employer that would benefit, that you'd like us to review, we're happy to do that. Just reach out to PBA. They are the key to this relationship and really have made it a very successful collaboration. They will work with you to help really identify other carriers that need to be brought into the loop, work with you all on that identification and referral process, help with the benefit design and removing the barriers from a benefit design standpoint, and what it looks like to cover travel and lodging and cover those out-of-pocket expenses that an individual may experience. And so also in this, we know that we don't want to just put the burden right from the employee to the employer, brokers, consultants, et cetera. And so what we've done is really tried to work with PBA in creating a turnkey approach where we even have summary plan description language. We have a marketing manager that works with us and supports marketing and communication efforts. So it's not something that you all or your employer groups have to create. We do ask that you take it through legal review from an SPD language standpoint and plan document standpoint. But again, it's relieving the burden for everybody in an effort to do what is right for these individuals and for the plan. So with that, I think we're going to open it up to discussion. So Jeff, I will go ahead and turn it back over to you.
Great. So if anyone has a question, go ahead and raise your hand. And what I'll do is I'll unmute you so you can go ahead and ask it. But in the meantime, I've got a couple of questions that I wanted to throw out there for you guys. So I think, knowing that cost is an issue, knowing that a lot of our brokers are very sensitive to cost, and Mayo is the creme de la creme of services here. What is your, how do you address Mayo being Mayo, the expensive, healthcare system versus seeking that local care?
Yeah, so I can start with that. So I think the point that we've tried to make throughout the presentation is that we're not looking for every individual to come to our campus. And so it's really identifying that small percentage of the population who need Mayo Clinic level care. And then we do have a direct agreement with PBA. So there are some special discounted rates that PBA is able to get for the care that happens at Mayo Clinic. And part of that is because of the breaking down barriers with travel and lodging and waiving the out-of-pocket expenses. So but really the ultimate goal for us is to have the long-term cost savings, the lower utilization, the right treatment plan, which is going to result in less care and less needs long-term. So we believe that our program is going to provide cost savings that will far outweigh the cost for kind of points of care. So Jeff, anything else you'd want to add to that?
And again, it goes back to the care you're not paying for. And that's the bottom line is when you're already spending this money with all these different specialties and you're going down these care plans that just really aren't creating the results you need, you're burning the plan's money, you're burning out the patient, going down roads of frustration. And so, based on what we've seen and what we've experienced, that's where we can really stand behind this this product. And that's why we're here today, really showcasing this. All right, so I'm doing some of my own admin here, and I don't see any hands raised. So I just want to make sure if anyone wants to throw up a chat saying, hey, I'm trying to ask a question, don't hesitate to do that. In the meantime, I do have one more question I'm going to throw out there. Just, thinking about what you guys have talked about, what are some of your biggest challenges that you've experienced, with possibly getting a patient into the Mayo system to really get that evaluation where maybe you've qualified them with the initial evaluation, but then it drops off right there?
Jeff, are you wanting Mayo to answer that question, or was that a question for the group? Okay.
Yeah.
Just wanted to make sure I was tracking with you there. So the question is really about how we're connecting the dots. Is that?
Yeah, well, the question is really, what's the biggest challenge you see? So you do the evaluation, and you say, yeah, we want to get this person in here. We think they're a good candidate. Do you see roadblocks at that point where they don't make it actually to Mayo because of reason X, Y, or Z?
Yeah, so I would say for the general Mayo population, yes. And the biggest roadblocks would be insurance coverage and out-of-pocket expenses for travel. So that's why with this program, we try to eliminate those challenges out of the equation and ensure that they have the access and the coverage from an insurance standpoint, and that we're removing those financial barriers that may prevent them from traveling for the care that they need. Other barriers that we have, I think a lot of it is really based on our collaboration with the service partner and with PBA. So ensuring that everyone sort of understands the program, some of the referral criteria, so that the right patients are getting to one of our Mayo Clinic campuses is kind of the most foundational, most important part of the program. And that's where having a partnership like we do with PBA is so critical, because the more that the case management teams are aware of the program and seeing the value and seeing patient experiences. Cheryl mentioned kind of that gut check. Often we can provide all the referral criteria that we want, but sometimes it's the nurse case manager is just knowing in their gut that this patient needs something more. This isn't working. The patient is not having relief of their symptoms. And so I think that is really where the benefit of experience with the program and experienced service partners and collaborators make this as beneficial as it can be.
Great. Well, thank you. You did answer my question. We actually have a question now. SJ Newcomb is asking if when returning home after a diagnosis and or services at Mayo, do you return to the original doctor at home or the one referred by Mayo?
Yeah, great question. So because Mayo Clinic is truly a destination medical center, all three of our campuses, our physicians are very used to every single day having patients who have traveled for care and are not living in one of our local markets to have that ongoing follow-up care happen at Mayo Clinic. So it's their everyday routine to ensure that we're understanding who the patient is working with in their local market. Often our physicians will offer to make a phone call to a local provider to talk through kind of their findings, their recommendations, the treatment plan, to ensure there's a collaborative relationship between the Mayo physician and the local provider. Or we make sure that they have access to all of the records and the clinical notes from the patient's visit as part of the program. In most cases, the patient goes back to the same local provider that they have been seeing. There's not a specific requirement for Mayo for a Mayo specialist to refer to a particular specialist in that market, and we'll kind of work with who the patient is comfortable with. If the patient is saying that they don't have a specialist that they are seeing, or they're struggling to find the right specialist, then our physicians can provide potential recommendations based on alumni from the Mayo Medical School that may be in their region, or colleagues that they may have. They may also recommend, if it's a patient who potentially would benefit from a clinical trial, and their local provider may not be at an academic medical center where that trial is offered, and perhaps across town it would be offered, they may recommend pursuing something like that as well. So it's really guided by patient choice and where the patient is most comfortable, but our providers are well-versed in collaborating with local physicians. We also have the ability via our portal for both the patient or referring physicians to reach out to our specialists and ask questions or check in or get clarification. So that's kind of an ongoing relationship that our providers are very used to managing. Great.
So I don't see any other hands raised at this point. Molly, Elizabeth, and Cheryl, thank you guys for taking the time and talking to us today and kind of going through your program. Are there any other points that maybe you haven't made yet that you want to make sure that the brokers and the clients that we've got on this call really, walk away with?
I think the only other thing that I would add, Jeff, is that when we are working directly with large employers, it can sometimes be a little cumbersome to try to figure out some of the processes and who's doing the identification and referral and who's managing some of that breaking down of barriers. So I think that the fact that PBA has a really turnkey solution with resources makes it a very simple. I think that was the title of the webinar, right? Trying to simplify the complex care process. I think that's what this collaboration does. It makes it simple, and to me, it's a simple way to provide hope to patients who need it most. And so that's our goal as Mayo Clinic and as this team that you have on here, is really just to provide hope for those individuals who most need it and to do the right thing for them. And so we appreciate our collaboration with PBA and are grateful for the opportunity to be with you all today.
And I'm sorry, Cheryl or Molly, did you guys have anything you wanted to add?
Nothing additional.
Great. All right. Again, thank you to everybody who took time away from either your lunch or your afternoon to join us today and learn more about this product. If you've got any questions, don't hesitate from a sales perspective to contact one of our sales reps or your client service rep at PBA to find out if you know of someone who's maybe in our system that you think could be referred to as well, because we really do want to take every advantage and every opportunity we can to make sure that we're taking advantage of this service. Thank you again, and I appreciate everyone's participation today.
Thank you, Jeff.
Thank
Bye now.
you.